Hello, my name is Wee Chong from the University of North Carolina at Chapel Hill, and I'm going to be talking about sonography of liver transplants. A number of conditions can be effectively managed with liver transplantations. Indications for liver transplantation include acute irreversible hepatic failure, chronic end-stage liver disease from cirrhosis from hepatitis B, C, or other infections, non-alcoholic steatohepatitis, Budd-Chiari or other forms of veno-occlusive disease. Hepatocellular carcinoma can be treated with transplantation if it meets a number of conditions, namely, if you have one lesion less than 5 centimeters or 2 to 3 lesions, none of which are greater than 3 centimeters. In children, the indications for liver transplantation include biliary atresia, congenital biliary cirrhosis, congenital hepatic fibrosis. From a cadaveric donor, the entire liver or part of the liver can be transplanted. In a split liver transplant, the liver is divided into two and the two portions given to separate recipients. In a living donor transplant, the right lobe of the liver is transplanted from one adult to another, and in a child, the lateral segment is transplanted from a donor adult. In an adult-to-adult living donor, segments 5, 6, 7, and 8 are transplanted. In an adult-to-child living donor, segments 2 and 3 are transplanted. This is an intraoperative image of a living donor liver transplant in progress. Here, the donor has been opened and the liver has been divided into two. The right lobe here will be removed and given to the recipient. This is the left lobe, which will be left to the patient. This is the falciform ligament here separating the lateral and medial segments of the left lobe. And this is a coronal MR image of the same liver in the recipient on the left side and the donor on the right side. So the recipient has received the right lobe and the left lobe remains in the donor. Imaging of liver transplants is performed with ultrasound as the primary imaging technique. CT and MR provide a global view for evaluating the whole of the liver parenchyma and is more effective than ultrasound for evaluating extrahepatic fluid collections. MRCP is particularly useful for evaluating the biliary tree. Angiography is used to confirm abnormal vascular ultrasound findings. The limitations of CT and MR and angiography are that immunosuppressive drugs are nephrotoxic, therefore limiting use of iodinated contrast and gadolinium in these patients. Also, susceptibility artifacts from hardware can cause problems with MRI, and there may be an increased risk of nephrogenic systemic fibrosis in the post-liver transplant state. The ultrasound technique for liver transplant evaluation first involves a grayscale recording of the liver and biliary tree. Then you evaluate the anastomosis. That's where the surgeon has joined the tube, so to speak. And there are 4 systems that need to be evaluated: the hepatic artery, the portal vein, the bile ducts, and the IVC. And there may be 1 or 2 anastomoses in the IVC, as I will describe. Doppler examination is performed of the common left and right hepatic arteries. Resistive indices and acceleration indices are obtained from these vessels. Then velocities from the main portal vein proximal to, at, and distal to the anastomosis are obtained. Doppler spectra are obtained from the left and right portal veins, and Doppler spectra from the right, middle, and left hepatic veins and IVC. Finally, a survey of the peritoneal cavity for free fluid and hematoma is performed. The outflow, that is to say the hepatic vein and IVC, can be anastomosed in two ways. In one way, the intrahepatic donor IVC is transplanted. So there is section of the recipient IVC, and there are two end-to-end anastomoses between the recipient and the donor IVC, one superior to the liver and one inferior to the liver. More commonly now, the piggyback anastomosis is performed. In this situation, the recipient IVC is left in place. There is only one anastomosis where the donor IVC is anastomosed to the stump of the recipient hepatic veins, while the inferior end of the donor IVC is simply tied off. For a fuller description of the AIUM guidelines for ultrasound examination of the liver, I refer you to this source, www.aium.org/resources/guidelines/solid-organ-transplants.pdf. This is a comprehensive protocol for scanning of all solid organ abdominal transplants. When you have a piggyback anastomosis, you can get this image which we call the 2 IVC sign. This happens when you happen to image in an axial plane that cuts across the donor IVC stump and the recipient IVC. So in that axial plane, as we can see on the CT image on the left, you see both the donor and the recipient IVC in a single plane, and this is the corresponding ultrasound image, and there are 2 IVCs visible, the donor and the recipient IVC. And this is a telltale sign that the patient has had a piggyback anastomosis. Complications of liver transplant can be classified as those arising from the liver parenchyma. These include hematoma, fluid collections, rejection, infarction, and malignancy, specifically post-transplant lymphoproliferative disorder. Disorders of the bile duct, including biliary obstruction and leaks, extrahepatic fluid collection and hematomas, and vascular patency. Again, the 4 tubular structures: artery, portal vein, hepatic veins, and IVC that are anastomosed. Vascular patency can be complete or partial, and anastomotic stenosis or thrombosis can occur. The hepatic artery can be anastomosed in the form of an end-to-end anastomosis between the donor and recipient hepatic arteries, or as a aortohepatic bypass graft. This is a typical waveform from the hepatic artery in a normal patient. You see a sharp rise in early systole and forward flow during the whole of the cardiac cycle, with positive flow during diastole. The resistive index here is 0.65, which is normal. The hepatic artery is the sole blood supply to the biliary tree, and patency of the hepatic artery is vital to survival of the graft. If the hepatic artery is obstructed, it leads to biliary epithelial necrosis and strictures. Therefore, establishing patency of the hepatic artery is one of the key tasks when you are performing liver Doppler ultrasound in the transplanted liver. On the top is a normal hepatic artery. The hepatic artery runs slightly anterior to the portal vein and is visible here on this color Doppler image. On the image below, this is a color Doppler image showing no visible hepatic artery. If you look closely, you can see a rounded hypoechoic structure which represents a thrombosed hepatic artery without flow. This is another case of hepatic artery thrombus. Here we see the hepatic artery in long axis as it arises off this the celiac axis here, but no flow is seen in the hepatic artery beyond this point. There is a thrombus in the hepatic artery just proximal to where it enters the liver, and the entire hepatic artery beyond this point is occluded. On the right is the corresponding angiogram showing the completely occluded hepatic artery just beyond the takeoff of the gastroduodenal artery. And this is the sequela of hepatic artery occlusion. The biliary tree epithelium will slough off, and 2/3 of patients will develop multiple non-anastomotic strictures, as you can see on this MRCP image. You have multiple areas of focal dilatation and stricturing within the biliary tree, and linear membranes running across the bile ducts, which are caused by sloughed biliary epithelium. And these patients would usually need biliary stenting to achieve appropriate biliary drainage. Hepatic artery occlusion is absence of flow within the hepatic artery altogether, but hepatic artery stenosis is a rather more subtle diagnosis, but it is something that should not be missed. We detect hepatic artery stenosis by looking for the Tardus Parvus waveform. And the Tardus Parvus waveform refers to an abnormal early slope in early systole. So this is the slope of early systole, and it should be very steep, like a very steep cliff, for instance. This, on the right side, is a patient with hepatic artery stenosis. On the left side is his normal hepatic artery waveform with a sharp rise, steep slope in early systole. And on the right, 3 months later, hepatic artery has become stenosed somewhere proximal to where we are interrogating the vessel. And note that the slope of early systole is much more shallow in this patient, and the peak systole is much lower and more rounded. So the resistive index, which is the difference between systole and diastole divided by systole, is reduced. It's less than 0.5, while the acceleration time, the time it takes to get from the beginning of early systole to where it starts to round off here, is prolonged. So the acceleration time is prolonged, and the resistive index is reduced. And this is known as the Tardus Parvus waveform. And here is the corresponding angiogram. Here we see a stenosis within the hepatic artery on this angiogram, and a stenosis in the hepatic artery proximally will create a Tardus Parvus waveform in the hepatic artery distally, which is where you are interrogating the vessel with Doppler ultrasound. Here's another example of a hepatic artery stenosis. This patient here has a thrombus within the proximal common hepatic artery visible on this MR angiogram. We are interrogating the hepatic artery distally inside the liver, and we see a Tardus Parvus waveform. The slope of the hepatic artery waveform is shallow, and there is a prolongation of the time it takes for the velocity to reach its peak, while the resistive index is simultaneously reduced. So we've seen that a low resistive index may be a sign of hepatic artery stenosis. What about a high resistive index? Well, that can mean one of two things. It is more commonly a benign finding. It is a transient finding that is often seen in the first few days after transplant and is associated with an older donor or prolonged graft cold ischemia. That's to say, the liver has been in a box for a substantial time after it's been harvested before it's transplanted to the recipient. And this usually normalizes after 1 week. And here's an example of high resistive index with no diastolic flow in a patient, and we're interrogating the right hepatic artery here. and this resolved after a few days and is usually a benign finding. However, if it does not resolve, it could be a sign of splenic artery steal syndrome. And this means that when you have long-standing portal hypertension, the spleen gets big, and so does the splenic artery. And post-transplant, there is shunting of arterial flow away from the hepatic artery to the splenic artery in patients with large spleens, creating a high resistive index waveform. Now, this is not a benign finding, and this has to be managed by reducing the shunting by embolizing the splenic artery. In the post-transplant portal vein, it is normal to see a difference in caliber between the donor and the recipient portal veins. The recipient's portal vein is dilated from years of portal hypertension, so there may be a mismatch in the caliber of the recipient and the donor portal veins, and that is normal. You may also see the anastomotic suture line, which protrudes into the portal vein at the site of anastomosis, and this may appear as a linear echogenic structure, and this is also normal. Portal vein thrombus is visible sometimes as an echogenic filling defect occupying the portal vein. In this case, Doppler is not necessary. On this grayscale image, the thrombus is clearly visible. Portal vein stenosis may appear as a focal narrowing within the portal vein that shows up on Doppler ultrasound as an area of elevated velocity. In this patient here, the peak velocity in the portal vein is 2.14 meters per second, and this is a high velocity and a sign of portal vein stenosis. Here's the corresponding MR image showing the stenosis within the portal vein. Now, in the immediate post-operative period, there are a number of changes that you will see in the Doppler waveforms that are a consequence of post-operative edema and should not be regarded as a cause for alarm. And these include high velocities in the hepatic artery, portal vein, and hepatic vein, turbulent flow, and this is due to temporary edema due to post-op, temporary narrowing due to post-op edema, and should not cause a diagnosis of vascular stenosis to be made in this period. So here is a patient on day 1, post-transplant, and we see that the portal vein velocity here is very high. It's 206 centimeters per second or 2 meters per second, and the flow within the portal vein, it has got a lot of spectral broadening. In other words, it's very turbulent. But this the velocity fell over the next week or so, and everything normalized. So don't make diagnoses of vascular stenosis in the postoperative period on the basis of high velocities, because these are normal. You may also see pneumobilia in the immediate postoperative period, which was introduced as a result of surgery, and this should not be regarded as a cause for alarm. And all these findings resolve in about 1 to 2 weeks after transplantation. In the immediate postoperative period, you should focus on the presence or absence of flow, hematoma, or thrombus. Now, what are the Doppler velocity criteria for anastomotic stenosis? Well, outside the immediate postoperative period, we know that a high velocity is suggestive of portal vein stenosis. Unfortunately, there is some overlap between normal and abnormal, and I'm going to give you here some numbers. Basically, a gradient of 2, basically a doubling of velocity between the pre and the anastomotic velocity, has a sensitivity of 71% and a specificity of 80% for portal vein stenosis. Now, if you want to set your threshold higher at 4, then your specificity is 100%, but your sensitivity drops to 57%. So here's a patient with a pre-anastomotic velocity of 0.31 meters per second and a anastomotic velocity of 1.53. So here, this is a step up of greater than 4, and this is 100% specific for a portal vein stenosis. If you prefer a numeric value, 150 centimeters per second or 1.5 meters per second, such as the patient, this patient has over here, has a 71% sensitivity and 90% specificity for portal vein stenosis. Slow velocities in the portal vein are also abnormal. This patient here has what we call to-and-fro flow, in which flow is almost stagnant. You can see it's less than 0.1 meters per second, and you have slow forward flow and then a little bit of reverse flow and a little bit of forward flow. So the portal vein is almost stagnant and the blood is sort of sloshing back and forth and with very little forward movement. This indicates high resistance to flow and may be caused by extrinsic compression. By a hematoma. In this case, there is a large perinephric hematoma here compressing the liver and causing increased resistance to portal flow. The other cause of slow to and fro flow is distal portal vein thrombosis. And this is the color Doppler finding in to and fro flow. Here we see a large hypertrophied hepatic artery here, which is this multicolored structure, while running just superficial to that, we see a portal vein which is flipping from red to blue, and this is caused by slow flow, to and fro flow with a very slow forward and reverse flow. The normal hepatic vein is phasic, with 2 forward spikes of flow and 1 reverse flow. These are known as the S, D, and A waves. And the normal hepatic vein has this phasic appearance with forward and reverse flow. A monophasic hepatic venous waveform is abnormal and can be caused by obstruction to the hepatic vein distal to the point of interrogation. You may also see elevated velocities and aliasing at the site of obstruction. So this is a patient with stenosis at the hepatic vein IVC anastomosis. Note that the hepatic vein narrows. There's a kind of waist here as it empties into the IVC. And we are seeing velocities of 1.3 meters per second at the anastomotic site. And this is high for the hepatic vein. And on the image below, we see that there is reversal of flow into one of the hepatic veins. So what is happening is that this hepatic vein here is becoming very stenosed as it enters into the IVC, and some of the blood can't get through, so it's backing up into this other hepatic vein branch. So reversal of flow in the hepatic vein, high velocities at the anastomosis, and you may see monophasic waveforms if you were to put your Doppler cursor more approximately in this hepatic vein. And here is the corresponding angiogram showing a severe stenosis at the hepatic vein IVC anastomosis, and this is being treated with balloon angioplasty. So you can do your patient a lot of good if you make this diagnosis on Doppler ultrasound. The interventional radiologist can successfully treat this problem. This is a case of IVC compression. Note that the IVC is reduced to this little narrow slit here, and this is caused by a perihepatic hematoma that is lying between the liver and the IVC, and this is the corresponding CT, and the hematoma appears as this hypodense area, and it's compressing the IVC, and this is impeding hepatic venous drainage. Now this is a rather unusual but very serious complication. This is a color Doppler image of the liver hilum, and we see some rather abnormal color Doppler appearances here. We see 2 large vessels, one in red and one in blue. On the grayscale image, we see that the portal vein is markedly dilated. This is a case of arterioportal fistula, and the red vessel is actually the hepatic artery, while the blue vessel is the portal vein. And what has happened is that the hepatic artery has fistulized into the portal vein, and there is a jet of arterial blood which is running in a retrograde manner down the portal vein. So hepatic arterial blood is blowing into the portal vein in a retrograde manner, as shown by this Doppler waveform. The Doppler cursor is now over the portal vein, and you're seeing arterial waveforms in the portal vein, but in a reverse manner, because the fistula has opened into the portal vein while pointing proximally. So the portal venous blood can't get into the liver. It's running into this jet of arterial blood which is pouring into the portal vein. And this is the corresponding MR image, which shows that there is earlier pacification of a dilated portal vein on this arterial phase, contrasted MR. So you will see that there is contrast in the aorta, indicating that this is the arterial phase, but the portal vein is already enhanced and is markedly dilated, and it is due to an arterioportal fistula. This is a rare but potentially serious complication that can lead to loss of the graft. Reported cases are seen in children, and particularly right lobe transplants, and they can present with varices and bleeding. This slide is a summary of the Doppler abnormalities in liver transplantation. In the hepatic artery, you should look for absence of flow. An occluded hepatic artery is a serious complication that can lead to the loss of the graft or serious biliary complications such as strictures and dilatation due to sloughing of the biliary mucosa. Elevated velocities at the hepatic artery anastomosis, low resistive indices of less than 0.5, and an acceleration time of greater than 0.08 seconds or 80 milliseconds can be a sign of hepatic artery stenosis. In the hepatic veins and IVC, you want to look for slow or absent flow, monophasic waveforms, and elevated velocities at the anastomotic site. These are signs of stenosis. In the portal vein, you look for absence of flow altogether, or which is a sign of thrombosis, but slow flow, less than 10 centimeters per second, may be a sign of extrinsic compression, while a velocity gradient of greater than 3 or 4 to 1 at the anastomosis or greater than 150 centimeters per second at the anastomosis can be a sign of portal vein stenosis. I'm now going to move on and talk about biliary complications, and these include bile leaks, anastomotic strictures, which can be at the common bile duct if there was a duct-to-duct anastomosis. Some patients have a biliary enteric anastomosis, and this is particularly common in living donor liver transplants, where the bile duct is anastomosed to a loop of bile that has been brought up to the resection margin. So there's a direct anastomosis between the bile duct and a loop of small bowel. Biliary necrosis, as I mentioned, can be secondary to hepatic artery obstruction and lead to mucosal sloughing and strictures in the biliary tree and biliary obstruction. Then there is sludge or stone formation. Patients with liver transplants have an increased predilection to forming sludge and stones, and there is also an increased incidence of sphincter of Oddi dysfunction. And this is an example of a bile leak. We see here there appears to be a fluid collection at the liver hilum. Remember that patients with liver transplants do not have gallbladders, so this is not a gallbladder. And this cholangiogram shows a leak of contrast from the bile duct at the anastomotic site. This is usually treated by stenting or sometimes percutaneous drainage of the biloma. This is a patient with an anastomotic stricture. Note markedly dilated proximal common bile duct and intrahepatic bile ducts here, as shown on this color Doppler image. And this is the corresponding cholangiogram showing a stricture at the duct-to-duct anastomosis. Isolated segmental biliary obstruction is seen with biliary enteric anastomoses, which are most commonly performed in living donor transplants. So in living donor transplants with biliary enteric anastomosis, the individual segmental bile ducts are separately anastomosed to a loop of small bile that's been brought up to the hilum. And these individual anastomoses can obstruct. So here we have a patient where you see a isolated dilated loop of a dilated bile duct, and this is the corresponding CT image showing the dilated bile duct, and this is the corresponding MRCP image. So only one segment of the liver is obstructed. The rest of the liver has a separate drainage from a different biliary enteric anastomosis which is not obstructed. This is a patient with sludge inside the common bile duct. And sludge can be difficult to see because in this case it is almost isocoate to the liver. I'm drawing my cursor here around the sludge ball which is sitting inside the common bile duct. And the only clue that you've got a sludge ball here is that you can see some intrahepatic biliary dilatation more proximally. And this is the portal vein running behind the sludge-filled common bile duct. Here's the corresponding cholangiogram showing lots of filling defects caused by the sludge inside the proximal common bile duct. This is a patient with stones inside the common bile duct. We see echogenic shadowing structures and the corresponding cholangiogram showing a stone that is obstructing the common bile duct sitting just above the duct-to-duct anastomosis. This is a patient with a large hematoma. So as part of our liver transplant scanning protocol, we do a quick survey of the extrahepatic spaces to look for large fluid collections or hematomas. Hematomas that are this size, this is about 15 or 16 centimeters, may require the patient to return to the OR for evacuation. Small hematomas, say under 5 centimeters, that are not causing mass effect or compressing on vital structures are usually left to resolve. Liver abscesses are associated with hepatic artery obstruction and biliary obstruction. They have a very high mortality, greater than 40%, higher than non-transplant patients. Liver transplant patients are all immune suppressed. They are often caused by unusual organisms like fungi, candida, non-albicans candida, cytomegalovirus or cryptococcus. And they appear as cystic areas within the liver. So when you see cystic areas within the liver, don't just dismiss them as, oh, these are just simple liver cysts. If you are dealing with a transplanted patient who is immune suppressed, think if this could be an abscess, particularly if ultrasound done a couple of days earlier had not shown these cystic areas. So a cystic area that suddenly appears in the post-transplant period could be a liver abscess, and the patient can rapidly go downhill if this is not treated quickly. And this is the equivalent CT of a patient with this liver abscess. Here you can see large fluid collections rapidly appearing in the liver that grow. And this is a corresponding MRI in someone with multiple liver abscesses Here on this MRCP image, we see high signal fluid collections that are budding off the biliary tree. And this patient had hepatic artery stenosis and with resulting biliary necrosis and development of little abscesses that are communicating with the biliary tree. Well, this is a patient with a cystic area inside the liver that is not an abscess. This patient had a liver biopsy, and by applying the color Doppler to this cystic area, one can see the classic yin-yang appearance of a false aneurysm caused by the liver biopsy. The hepatic artery has been punctured at this site, and there is a leak of blood into this cavity, creating this swirling appearance of blood, or the so-called yin-yang sign, which is classic for a false aneurysm. Post-transplant malignancy can be caused by post-transplant lymphoproliferative disorder. This is a B-cell disorder caused by the Epstein-Barr virus and presents 6 to 18 months post-transplant due to the immune-suppressed state of the patient. It is a form of non-Hodgkin's lymphoma. Hepatocellular carcinoma can also occur, and it can recur in patients who have had a transplant because of HCC. And cholangiocarcinoma can occur if the transplant was performed for primary sclerosing cholangitis. Patients with PSC have a greater predilection to developing cholangiocarcinoma, and this predilection carries over even though the patient has had a transplant. PTLD rarely involves the liver itself. It appears in the form of lymphadenopathy or perihepatic masses. In this patient here, we see a hypoechoic solid structure between the IVC and the aorta, which is a large aortocaval lymph node. This is a case of recurrent HCC. This patient had hepatocellular carcinoma in his liver, and he had a transplant, but a little bit of tumor may unfortunately have seeded during the transplantation process, and it appears as a mass which is visible adjacent to the liver in Morrison's pouch on this HASTE sequence. This is seen to enhance post-contrast, and the image on the bottom is following radiofrequency ablation performed by our interventionalist. The little residue of HCC here has been successfully ablated. In conclusion, major biliary and vascular complications of liver transplantation can be accurately evaluated with cross-sectional imaging. Ultrasound is the first-line imaging modality in the immediate post-transplant period.